We request Dr. Gopichand to join. Gopichand, sir. Dr. Gokhale, sir.
This is the change. The change is here.
Next, back pointer.
This is forward.
Next.
Yeah, okay.
Can we call Christopher, sir? He will introduce. Christopher, sir, మీరు చేస్తారు కదా
ఇది ఇంట్రొడక్షన్
చేస్తాను మీ
Actually, it is my privilege to introduce Dr. V.V. Bashi, who has been selected for this year to Dr. K.V. Naidu Memorial Oration. We have a long association, not only as a surgeon, even my surgical training too. When I joined at CMC Vellore, he already completed his MCH there, and he was the blue-eyed boy of Professor Stanley John. Even today, I think he is the most cherished disciple of Professor Stanley John. He did his MBBS in Kerala, and again MS General Surgery there, MCH at CMC Vellore in the University of Madras, and he has been conferred FIACS and FACS. He had his training in Australia. After working for some time at CMC Vellore, they went to Australia and then came back. And over almost 4 decades, he has a very rich experience of doing more than 15,000 surgeries, and most of them, of course, are the coronaries. And the one area where he is very well known, not only in India, even abroad, people call him from American societies, European societies, to hear his experience is in the area of aortic surgery, especially the dissections. He has done more than 1,500 aneurysm surgeries. These include 400 root replacements, 150 aortic arch replacements, thoracoabdominal aortic operations, hybrid procedures. No wonder a lot of cardiologists refer to him, but I have to tell you that even as a surgeon, I have referred a few cases to him because I thought they are beyond my capability. And he operated many of them. They have been doing very well. Especially, he is very good in redo aortic aneurysms and coronary surgeries. And today, he is the president of Indian Association of Cardiovascular Surgery. He has just taken over a week back from the previous president. He is working as chairman and a chief surgeon at which is the hospital you are working in, Bashi?
Sims Hospital.
Huh?
Sims Hospital.
Sims Hospital, yeah. Before that, he was at Miyot, and he worked at Malar Hospitals, and then he was, of course, worked with the KM Cherian also for some time. His professional achievements are huge. As you can see, he is one of the very few surgeons who has a lot of publications. Even from the days when I was there, he published some of the publications on constrictive pericarditis, pericardiectomy those days. He is a fellow of American College of Surgeons, life member Indian Association of Cardiothoracic Surgeons, and lot of things. And he has given many guest lectures in India as well as abroad. With this, I think whatever I tell is like a drop in the ocean of Dr. Bashi. And he's one of the most dependable surgeons, very well respected by his colleagues, not just by patients, because to get a respect from colleagues is always difficult. We always have something to comment, but it's one of those rare personalities. Thank you, Bashir, for giving me this opportunity.
Thank you, Dr. Gokhale, for the kind introduction. I feel very humbled to stand in front
I think, Bashir, before you give your delivery oration, we need to give you the gold medal. Gold medal.
At the outset, I thank Dr. Kondal Rao and the Cardiological Society of Telangana for giving me the privilege of coming here and giving this lecture. I feel very humbled, and thank you for the extensive introduction, Dr. Gokhale, who I know for the last 3.5 decades. Incidentally, when I was invited to give this oration, I was very happy and immediately accepted because Dr. K.V. Naidu was my examiner for MCH in the year 1982. Dr. Gopinath, Dr. Stanley John, Dr. Jayaraj and Dr. K.V. Naidu, he was alumni of our CMC, Christian Medical College Hospital, where I am very proud of him. And he used to be, I used to be one of his fond pupils. Whenever we meet him in the conference, we had a few times he have come and referred patients. And those days, no other much cardiac surgery was done in Andhra those days. So he used to be a big teacher, an ardent, hard-working surgeon. So my pranams to him before I start this lecture. So I was asked to talk on aortic dissection. So I cannot finish this in 20 minutes, so I'll just go through the basic things which is relevant today, basically for people who manage aortic dissections. So no talk about aortic dissection is complete without Michael DeBakey, who was the first surgeon and the oldest patient who underwent aortic surgery. He is the one who did the first case, and at the age of 96, he underwent a successful type A dissection. Initially, they were debating whether to operate him or not, and finally he underwent, after a stormy post-operative period, he survived. And now, dissection is an event which results in separation of the layers of the aorta, and depending upon the extent, only either you survive or reach the hospital. And acute type A dissection, the entry point is in the ascending aorta, as you know, and the extent of the dissection and the hemodynamics of the patient depends upon the number of tears in the ascending aorta and how much and how long it extends to the different regions of the aorta distally. And now the risk factors for aortic dissection, all of us know, basically bicuspid aortic valve, patients with non-aortic aneurysm, and most importantly, uncontrolled hypertension. One of the main reasons, most cases which come to me, I have noticed a lot of patients don't take hypertensive medicine properly. Then patients with previous cardiac surgery, which is one of the other causes, and this is the age-old classification. DeBakey's type 1, 2, 3, and Stanford type A and type B. Both the Stanford classification is followed more frequently now. And then depending upon the duration of the dissection, it could be acute, which lasts for within 14 days, or chronic when the patient comes more than 14 days, and subacute within 90 days when they come. In the frequency of primary tear in type A dissection, as we all know, it is more 80% in the ascending aorta, and type B, it is more in the descending aorta, more than 80%. And now the life-threatening complication of aortic dissection can be depending upon the involvement of the aortic valve, occlusion of the coronary artery, rupture of the aorta, tamponade, ischemia of the viscera, or cerebrovascular problems. Now, clinical features: severe pain, tearing in interscapular pain, can present sudden death. It can mimic acute myocardial infarction. I have heard a lot of cases coming after thrombolysis from peripheral centers. Nowadays, a patient coming with acute chest pain in our unit, if we straight away send the patient to a CT aortogram, we have any suspicion, because that has really helped in diagnosing more cases and not which was not available earlier on. I had at least more than 6 or 7 cases where patients were thrombolyzed and had problems post-operatively operating them. So the depth of the issue, if you see, 33% of the patients die within the first 24 hours and 50% die in 48 hours. In 2 weeks' time, only 75% patients die, only 25% will be alive. So those who come to us are basically who has survived the acute problem, and then they becomes easy to treat. The most difficult problem when the patient come acutely with a torn aorta, it is surgically very difficult and technically more challenging. And the chest X-ray, the most important thing is the investigation which has really revolutionized the treatment of aortic dissection, CT imaging. It is very important to analyze the CT and assess the details, finer details, evaluate the entry points, evaluation of the arch and visceral vessels, so that we are not surprised on the table, because earlier on when this was not available, when you open only you know what is to be done. It's a very difficult situation. In the middle of the night, most of the patients come late, so we are really difficult to find out what is to be done. Another investigation which is also equally effective is a transesophageal echocardiography, which can detect mainly the false lumen as well as the aortic valve incompetence and the morphology of the aortic valve. Now, the importance of the aortic team, I cannot overemphasize the importance of the team. It's so important that all these teams work together to get a good result, because in a type A dissection, once it is very complex, somebody has to be there to diagnose it. Then we have to have the anesthetic team, the perfusionist should be available, and interventional cardiologists also should be available in case we have to do any stenting to tide over any visceral malperfusion or any malperfusion of the other viscera. All these are very, very important to get a good result. An approach in an emergency situation, when the patient comes, the most important thing I find is the control of blood pressure, because when a patient comes, nobody bothers much about that. They'll be trying to arrange the theater and everything, and somebody has to be really noting about the blood pressure and managing the patient, because I have had instances where patient has come to the casualty and died because of hypertension and rupture. Patients on the way shifting to the theater has died. Patients have died in the ICU of rupture. So once it ruptures, it is almost impossible, even inside the hospital, to save the patient. So the principles of treatment in type A dissection is to resect the tear in the ascending aorta. Most of them present with the tear in the ascending aorta, then aortic valve will be involved. If the aortic valve is badly damaged and the sinuses are thin, we have to do a root replacement, or we may have to do a valve sparing procedure. If the valve is good and the patient does not have much of connectivity disorder and the sinuses are good, one can preserve the aortic valve. But of course that is done by only inexperienced hands, because preservation of the valve is not easy in an emergency. The distal limit of the treatment depends upon the involvement of the aortic arch, proximal or total arch, sometimes the descending aorta also, distal to the subclavian. The frozen elephant trunk, which is mentioned there, is not done in many centers. Actually, in a few centers in the world only it is being done. We are one among them who does frozen elephant trunk in acute dissection, because this is very useful so that patient will not come back with problems later. So in a management of the acute dissection, these are surgical details only. We cannulate wherever the artery is available, and this is a case where a valve has been preserved. You can see the dissected aorta. The distal anastomosis of the graft is done under circulatory arrest, and we are just checking the valve for the competence. So if the valve is good, we can just replace the ascending aorta and fix the tear. So in this case, we just preserve the valve. So if the valve is badly damaged, or if the sinuses are thin, you go for a root replacement. Now that's my experience with aortic surgeries, and this is a total about 278 cases, and we can see that we have good results because in the last 15 years our mortality is equivalent to any international center, because the experience is the most important thing in managing aortic dissection. Each case is a teacher for you. This patient who underwent a root replacement is a Marfan's syndrome patient. Another patient who we did only the ascending aortic replacement, you can see the valve is competent. These are a few examples. And this is another case where a patient has come with a dissection after a coronary bypass surgery. Type A dissection is a chronic dissection and replace the ascending aorta with the reimplantation of the grafts there. If the ascending aorta alone is tackled in the initial operation, what will happen? The distal tear in the distal aorta keep increasing. So it is not addressed in many of the centers because in an emergency situation, you may not find an experienced surgeon to tackle the whole thing. In an emergency, it may be safe to just replace the ascending aorta and later on tackle, which can be done by an experienced surgeon later. Because if you try to tackle the whole situation together, the mortality definitely will be much higher. Now just to show a few of the patients whom I have operated, when they do an ascending aortic replacement or root replacement alone, what happens over a period of time? Sometimes after 5 years, 6 years or 10 years like that, patients keep on coming with increasing size of the descending thoracic aorta, which has to be tackled. And this is a patient who came with a paraplegia in our hospital. This particular day, I did 4 aortic dissections in 36 hours. One of the patients was this only. After the second case, while I was doing the first case, this fellow came with a paraplegia. He had a spinal cord, blood clot in the spinal cord. So we did for a salvage, we did ascending aortic replacement and then arch debranching and put an endograft. And then that was the post-operative picture which we saw earlier. Now this is the first case of type A dissection I was telling. This patient came with a type A dissection with a distal tear. And that is the post-operative picture where we did the aortic arch and descending thoracic aorta with an endograft. This is a hybrid, it's called a frozen elephant trunk, which is not done in many centers. The graft was also not available, we got it only last year. This also is a very complex operation which involves a lot of precision in managing in intraoperative and post-operative imaging also. Now malperfusion, that is the biggest problem in type A dissection. Malperfusion, when there is loss of blood supply to a vital organ. Malperfusion syndrome, when the end organ is ischemic and it is infarcted. And it depends upon the problems, depends upon which area is malperfused. This is the second most common lethal complication in acute aortic dissection after rupture of the aorta. Rupture of the aorta is the commonest problem. Incidence varies from 10 to 33%. So this is malperfusion. The frequency of malperfusion is that the most frequent is renal, then comes coronary, then comes spinal cord malperfusion, limb, and cerebral malperfusion. All studies have confirmed that malperfusion has a negative impact in hospital mortality as well as long-term survival. When does it occur? Usually it occurs at the time of dissection, during false lumen thrombosis and occlusion of the branch vessel. Sometimes after initiation of cardiopulmonary bypass, we have problems, because the pump pressure goes up, patients are not able to be perfused. Sometimes when we apply cross clamp, malperfusion occurs. Also after the repair, malperfusion has happened in different cases. The mechanism, it could be static obstruction or dynamic obstruction. That is, static obstruction is a dynamic because of the flap obscuring the lumen of the renal artery. In this case, if you correct by the correct central repair, the malperfusion will disappear. Whereas this type of things may require additional intervention for treatment of malperfusion. Shall we operate on all these patients? Shall we first treat malperfusion? What is the outcome when we do surgery? Let us see. Rapid restoration of blood into the true lumen is the most important thing. So address the following: which lesion to be treated first, whether the central aortic repair or we have to do the peripheral repair. So in most of the coronary malperfusion, immediately we should do the primary repair, and we should protect. The problems in coronary malperfusion is protection of myocardium. When the coronaries are dissected, it is difficult to give cardioplegia. We have to give retrograde cardioplegia. Then we may have to repair the coronary arteries and do a bypass surgery, which makes the operation more complicated. Now this is the surgical techniques of repairing the coronary arteries when the coronaries are dissected. And this is the intraoperative pictures where we do the coronary bypass, the Cabral technique with the interposition grafts. Now management, myocardial malperfusion, straight away take the patient to the operation theatre, correct the malperfusion by doing the central repair coronary bypass surgery. So cerebral malperfusion fortunately is less, 6 to 14%. And when it happens, medical therapy is 100% mortality in patients with coma and 76% in patients with cerebrovascular accident. Surgery has a protective effect against mortality, about 50% survival benefit in cerebral malperfusion. So the patient is conscious, patient has got a cerebral malperfusion, shift to the OR, you do the operation immediately, irrespective of whatever the condition. Whereas the patient is unconscious, definitely we defer surgery unless the relatives are really willing to take the risk. Mesenteric malperfusion is one of the most difficult problems in aortic dissection. It occurs in about 4 to 6% of patients, and 2/3 of the patients die during hospitalization. So when the patient comes with the mesenteric malperfusion, they will have a lot of metabolic problems, acidosis and hypotension. So usually it is corrected first. When we do the mesenteric malperfusion, usually we correct the mesenteric malperfusion first before we undertake the surgery, because the risk of surgery is very high. This is a paper which we have published in seminars in the American Journal recently regarding malperfusion. So the patient is stable, hemodynamically stable. You fenestrate the dissection and improve the blood supply and do a central repair. But if the patient is hemodynamically unstable, central repair with the bowel examination, whatever it is, the mortality is very high, especially when there is necrosis of the bowel. Limb ischemia usually is not an uncommon thing. Usually most of the time, a central repair will correct the limb ischemia. If it is not corrected, we have to do a thrombectomy. This is a patient whom I operated. But you can see the right side, the limb ischemia has already relieved after the operation. This is another patient also, where the patient came with an acute obstruction of the aorta just below the renal artery with the paraplegia, and after correction, you can see the aorta below is filled nicely. And renal malperfusion is most challenging. It may be perpetuated by obstructive dissecting flap or contrast injury. This is one of the patients with the type B dissection. You can see he was being dialyzed, and after a frozen elephant trunk, his kidney is actually nicely, blood flow is very good. One kidney is less, but the patient came out of dialysis in 1 week's time. So dissection in Marfan's patient is always a problem. These are the cases of my own series where patient didn't have any problem in the proximal distal aorta when I did the Marfan's root replacement for annular aortic ectasia. Patients coming after 3 years. The earliest patient was who came after 3 months after the root replacement, coming for the distal dissection. This is how it progresses. This is one of the patients where the disease has progressed after the first operation. This is also another young patient with Marfan syndrome, finally, who underwent a total endovascular repair with a fenestrated graft. And this is another problem, because retrograde dissection is after stent implantation. One of the complications of the type A implantation of stent after type B dissection. This is a chronic cases, acute cases. The mortality is almost 100%. These patients come and give us time to repair. Now the challenges in our country, problem is, the most important thing is transportation. Get the patient as early as possible, availability of centers who are capable of doing, and expertise, lack of awareness among the people. So all these contributes to the problems which we face. Aortic surgeons and the team, as I said, is very important. Cardiologists, radiologists and vascular surgeons should work together, then only we can achieve a good result. And because of the country is so huge, air ambulance has not picked up, and also is not beyond the scope of common man. We have we took the statistics and found in India almost nearly 600,000 patients may need aortic surgery. but in reality, it is very less. I just took a statistics roughly and find we are doing only 400 to 450 cases of type A dissection, and majority of the patients are younger compared to what you see in the Western countries. So whether the incidence is low or do the patients die before they reach the hospital, it is a very difficult question to answer. So when the change, we don't have all the available things which is available abroad. All these things are available, all the graphs, expensive things, but when it is not available, we are actually making our own ways of making it. Make a graph by ourselves, then do the fenestrated graphs, stitch by hand, and also endographs we modify. So with that we are able to give service to our people who are not financially that good, especially most of these operations are very expensive beyond the scope of a common man, especially when they come as an emergency. Our biggest worry is not to do the operation. That is, of course, we are trained to do that, but to arrange the finances so that we can do the best possible, because it's all highly complicated. If you try to compromise, your result will be different. So to conclude, type A dissection needs emergency surgical therapy. Bentals or David procedure depending upon the anatomy of the root. Malperfusion is a very serious problem, and one has to take a decision according to the clinical condition of the patient. When you see the patient, distal aorta is a challenge which has to be tackled later. Multiple challenges to overcome in Indian settings, and frozen elephant trunk, which I showed, is a good operation to get good long-term results. And thank you very much. Once again, I thank the Cardiac Society for the invitation and the privilege of talking to you. Thank you very much.
Please come and thank you very much. Thank you, Dr. Bashi. On behalf of the Cardiology Society of Telangana and my colleagues, Dr. Seshgir Rao, Dr. Kondal Rao, and other members, it was extremely heartening to know that Dr. Bashi has specialized in this field, where I don't think many cardiac surgeons in India have even thought of doing these things. It is also very appropriate that he is giving the memorial oration on behalf of Dr. K.V. Naidu, who was one of the eminent surgeons of the state. He died very young. He used to be the professor of cardiothoracic surgery at Nizam Institute of Medical Sciences, Usman Medical College, and also subsequently at SWIMS, Tirupati. He died young. However, all his life, he spent time in nurturing the cardiac surgery, giving support to the young surgeons of those times, including myself, who was the assistant professor when he was professor at Nizam Institute of Medical Sciences. I take this opportunity to congratulate Dr. Bashi, who is also president of the Cardiac Surgeons Association, for giving this excellent lecture and giving insight to the various aspects of the aortic valvular disease. Thank you very much. I also take this opportunity to present the certificate.
Thank you. All the speakers and faculty members, please collect your mementos, whoever not collected from the organizing committee. And we do have a general body meeting at 7 p.m. And we have a lucky draw for you people. You can fill the coupons near the bullet vehicle stall number 2. So whoever not yet filled, you can fill the coupons, and one of you may be lucky for getting a bullet vehicle. We do have a session on structural heart interventions now. May I now call upon Dr. R.K. Jain, Dr. V. Rajashekar, Dr. M. Gokul Reddy, Dr. Ram Subramaniam, Dr. Pramod Kumar, and Dr. Narsaraju, and Dr. Vikram. And the moderators, Dr. Sanjeev Kumar, Dr. Ashish Nima, Dr. Shyam Sundar Reddy, Dr. V. Hariram. I request now the chairpersons to conduct the session.
I request the first speaker is Dr. Srinivas Kumar, expanding indications for tower.
Respected chairpersons and my dear friends, thanks for the opportunity. Dr. Kondal asked me to talk on something related to TAVR. I think all of us are becoming more and more interested in this new modality, which is wonderful therapy for sick patients, and that's how it's picking up. And my subsequent speaker, Dr. Anuj, will speak on the basics and steps. This is worked out very well for the building up of tower program, because not only me, 27 of our cardiology colleagues also search for patients, and fortunately also this got recognized recently in European Heart Journal. I specifically want to project this. This is where we need to work together, network among our colleagues and help patients and have good work-life balance amongst all of us. That's how we are struggling. Apollo was also happy because Apollo got into European Heart Journal with this. Then fortunate to have association with FACS, with Columbia University, especially Dr. Sushil Kodali, who has been instrumental in establishing valve program in our place. And thanks to our big country, huge country, and presence of Apollo in various places, we got referrals from various home of the states which has sent, and that's how the volumes could be built. Back to tower. This is again, as you all depict there, you have aortic stenosis, calcific, which sometimes surgeons are also worried in sick patients to touch. Now it is being done either with balloon expandable valves or self-expandable valves. The cartoons are shown there. We're all thankful to this great man, Alan Kripia, who recently visited Apollo also. Did this procedure in 2002 in a sick patient about to die, not fit for surgery. Of course, that was an integrated procedure through transeptal puncture, and the patient was not fit for anything. And dramatically, through his surprise, as Kripia mentions, within 15 minutes, patient became like that, and he took a picture with this. So that's how the therapy evolved. And it has evolved so much that we are all thankful to this great man, Eugene Braunwald, who recently celebrated Golden Jubilee. We all know the classical triad of aortic stenosis, exertional angina, breathlessness, and syncope, which was given the natural history of aortic stenosis. The TAVR has evolved so much, now we have a separate classification and then proposed based on the TAVR outcome results. Now what they say is they classified this aortic stenosis into stage 0, 1, 2, 3 and 4, depending upon the involvement of valve alone or the left ventricular damage, pointer is there, or if it is also goes to the stage of mitral valve and then also on to right ventricular failure and pulmonary arterial hypertension. Previously, we used to think PAH happens only in mitral valve disease, but it's proven wrong, which we also had one patient which I'll briefly show. So why it is important to understand this natural history is, if you address these patients very early, the mortality and death problems is very less here, 4%. Whereas if you wait longer, it is going up to 25%. That's very important to have this structural deformity happening secondary to aortic stenosis so as to prognosticate these patients. And then that's how it initially, after the heart valve team discussion and probably being tried in prohibitively high risk surgically inoperable patients, then gradually partner trial is one of the best ways how the therapy has evolved, planned it very well. Initially tried for non-operable patients, then high risk surgical patients, then moderate risk patients, then recently we again went on to do even in a low risk patients. So this evidence for TAVR is huge now. The partner cohort B showed that compared to standard therapy, which was decimal, many people were dying, TAVR produced a lot of mortality benefit. And this median survival benefit is not there so much compared to any other profession in interventional cardiology. 30 months additional life. Quality of life also improves dramatically with TAVR. And then results are proven equal to surgery. And then valve durability was questionable, but the same valve which was surgical colleagues were using now is being done, and we have data up to 10 years. Then core valve also went to surgeons saying that proved results superior to surgery first time. And then of late you have partner 3 trial which was presented in ACC, showed that even in low risk patients there is a lot, this produced a lot of benefits compared to our surgery. So where surgery is still better is probably in the incidence of LVB and valve regurgitations and gradients, whereas almost both are same in the incidence of pacemakers and coronary other problems. But TAVR scores much more because mortality is much less, strokes are much less, hospitalization, acute kidney injury, bleeding, new onset of atrial fibrillation, quality of life, ICU care, and probably shifting very early out of ICUs and discharge. These are all TAVR is much better compared to surgery. So we have come from an era where we were worried to do this procedure. Now it is proven beyond doubt. If you ask any child also, will tell which is better, because so many advantages on the right side with TAVR. Many people obviously would prefer less invasive TAVR procedure compared to surgery. How did it all happen? It all thanks to technology. This structural heart disease evolved right. It's almost like a stent which we had about a decade back. You know cipher stents which are very tough, not very easy to negotiate. It's something similar, but we have this still more 14 French, but it is a balloon expandable, they're easy to implant, behaves like a surgical bioprocess in long term. So that's how it is usage-wise, it is relatively easy like stent, but behaves like a surgical processes. Where are we in 2020 in TAVR? In mortality-wise, a patient asks you what is it? It is about 3%, disabling strokes less than 3%, vascular complications less than 5%, bleeding complications, and we need to be a little careful by evaluating patients properly. And then paravalvular regurgitations. Now this problem is also being taken care by more of our latest versions of TAVR valves with various type of modifications coming up to decrease paravalvular regurgitation. But what is more important is the role of heart team, preoperative discussion of these patients and procedural details. We need to have discussion. And the physicians on the team, the cardiac surgeons, and team strengths and weaknesses we need to know. And without going into too much hospital politics and trying to contain the cost, we need to give this. That's how this has got established itself. The heart team approach, though we say many times, it's a real coming to use, I feel, here after this TAVR advent, because now keeping the patient's interest in the center, both surgeon and we, I think at Apollo, Dr. Gokhale, Dr. Dikshit, we all actually were talking many times to do which procedure is good for the patients. Coming to some of the case examples and evolution of TAVRs, apart from inoperable and some of these moderate to low risk patients, some of the interesting cases which we did in the last 6 months to 1 year, I would briefly share here. An elderly patient with LV dysfunction CKD, we were actually worried whether CKD would worsen before we did this procedure. Severe calcific AS, moderate LV dysfunction, patient got admitted with LVF outside, and then we did TAVR procedure again with the self-expanding valve there, and the patient did well without much of problems. And we actually counsel the patient that LV will take some time for it to recover back, but pre-discharge echo itself, from the severe LV dysfunctional stage, that sort of mild LV, much significant improvement happened post-TAVR. And again, the valve post-bioprosthetic degeneration, 70-year-old surgeon was not willing to operate. Initially, we thought it would be more difficult to do this case. But what we realized is if you already have a prosthetic valve patient there, provided you put the appropriate sized valve process is there, it's more easy to deploy this newer valve there, and valve sits well. And that's how this was now done more comparatively, relatively easier compared to the native valve. This is that's how the patient improved, and the contrast was minimal, creatinine didn't worsen. Post-bioprosthetic mitral valve, this is again a very highly influential lady related to Apollo management, others, and she had a severe PAH. We were worried whether this patient would improve because mitral valve was functioning all right, but still she had severe PAH. After they did the procedure, the three-dimensional, if you have to see that ring which you see is actually mitral valve ring. We carefully did it, and there was no problem. And after the procedure was done, the patient's PA pressures from 80 decreased to 50, and she improved dramatically. So that's how we are becoming more and more confident. This is a TAVR in a balloon aortic valve, or bicuspid aortic valve. This India, somehow we see more of this. In younger patients, this is again Merrill, India made Merrill valve, my valve of Merrill. Again, works almost behaves like Edwards valve, balloon expandable valve. It comes in various sizes. In bicuspid aortic valves, we probably take the help of balloon dilatation before, and then probably position the valve, and pacemaker rapid pacing is again mandatory in this, and then we need to be careful in positioning our valve to avoid too much oversizing with calcium, sometimes could rupture, and fortunately this patient did well. And the porcelain aorta, you see the entire aorta is moving, and again patient did well. So this is all we struggled because the sick patient is referred from Nagpur, again went for voting. Other patient was shifted from Khammam with severe LV dysfunction, heart failure, Lasix infusions. Next day patient sits up and becomes happy. All this gives us very lot of happiness. Newer versions of TAVRs coming up to make the procedure more and more easy to prevent paravalvular leaks and other things. And newer versions of Lotus valve, others which are repositionable, also will help in easing the procedure further out. So the reality is TAVR works. Patients and physicians want a less invasive therapy. Risk-benefit thresholds vary with age. We need to have a heart team approach and probably discuss this in detail with the patients. TAVR, other expanding indications, again, after it is proven even in the low risk, now cardiologists are very smart, and we tend to get a newer hypothesis. The bicuspid aortic valve, anyway, it started doing again. I'll finish in 10 minutes, half a minute. Aortic stenosis, concomitant disease like coronary artery disease, mitral regurgitation, and then the trials on the way. Severe asymptomatic AS, if again patient is why wait till it becomes worsens before symptoms, and moderate aortic stenosis, unload LV, like before it becomes severe, or some LV dysfunction may decrease the gradients, that's unload LV also is being tried. High risk severe AR, and many patients are also being taken. Only isolated AR also TAVRs are being attempted. That's how we have very bright prospects, and many of the sick patients improve with this dramatic therapy. Thank you very much for patient hearing. You learn more from coming TCT in July. Thank you.
Thank you for excellent talk, Dr. Srinivas Kumar. I request Dr. Anuj Kapadia to talk on step-by-step approach to TAVR.
Good afternoon, everybody. Thank you for giving me this opportunity, Telangana CSI. It's a huge topic. I'll just rush through it. I'll just give you the gist of this. Now, coming to the approach, the step-by-step approach to TAVR, I think the most important thing in all this is before we get the patient onto the table. It's about the pre-op discussion of the team, the planning, pre-procedural planning that we do. That actually determines the whole thing. Probably to put it across, probably it's about the pre-procedural planning and the CT reading first. Second is the valve axis, which actually constitutes probably 75 to 80% of the whole procedure of TAVR. Now, coming to, I won't stress more about the anesthesia part of it. There's no doubt that conscious sedation is an amazing thing to do. But conscious sedation versus GA, for somebody who's actually starting the process of TAVR in the hospital, I think GA would be better, because in case a patient moves, or if you have a great anesthesia team, fine, but if somebody is yet to learn, better to go ahead with GA so that you are at mental peace when you're going ahead with your procedure. I'd like to discuss this in 4-5 headings: the access site, the valve crossing, pre-dilation, valve positioning, post-dilation, and the immediate post-op assessment. This is the most important part of actually TAVR. Now, coming to the decision of your puncture site, I think this also is based out of your CT. You basically have to puncture, have an anterior, your basic goals of puncture is an anterior puncture, which has to be below the inguinal ligament, midway of the femoral head, above areas of avoiding areas of calcification, and above the bifurcation. This, I think, we will have a good idea through the TAVR, CT TAVR, where they actually delineate the femorals and the iliacs. Our basic idea is to take 3 arterial sites and 2 venous sites. So basically, you'll need 1 secondary site and 1 primary site and 1 arterial site for monitoring, and 2 venous sites, 1 for the TPI and 1 for infusion of all your fluids and inotropes. Now, coming back again to this, the access, basically we go at our center, we go ultrasound guided and fluoro guided. It's a combination of both, and of late we've actually started doing the railroad technique also. So and in all cases, irrespective venous as well as arterial, we take a micro puncture. Now I'll just go through this. Now this is a micro puncture set where we first take a needle holder, mark the middle of the femoral artery with the fluoro, also do an ultrasound, don't move the table after that, and with the micropuncture set we take access of the femoral artery above the bifurcation, take a check angio with the micropuncture sheath itself with the dilator there, and then over that we actually thread the short guide wire, and over which we take the 6 French sheath. Now, once we secure this, we take a Lima catheter up to the bifurcation, cross up to the bifurcation, take a check shot there, which actually helps us to delineate the artery on the other side, which is the secondary side. We mark it with our finger and also with, and then we puncture according. This is if you can see the third fluoro. Based on most of our cath labs now, we have the railroad, where we actually use the railroad to actually puncture the contralateral side. Now, which to take as a primary side, primary access site, and which to take as the secondary access site is decided by 3-4 things. One is the diameter of your artery, the calcification of the artery, and the tortuosity of the artery. Now, diameters less than 5.5, though we have done a 5 millimeter vessel also, but generally diameters less than 5.5 we generally try to avoid as a primary site, and better to be around more than 6 millimeter. Calcification has to be avoided, because if it is a circumferential calcium which is extending beyond 270 degrees to 360 degrees, it will not expand, it will not allow the hardware to go through, and better to avoid a focal site of calcification, because your proglides will not help in closing the artery. So, and The less tortuous the artery, the better is as a primary site, because you are going through with quite bulky devices. So basically what a dangerous arterial anatomy is arterial diameter less than 5 millimeters, severe calcification, severe tortuosity, and severe calcification with severe tortuosity is a definite no-no. Now crossing the aortic valve, generally through the secondary axis we put in a pigtail in the non-coronary cusp. We take an aortic root angiogram in the coplanar view to look for any aortic regurgitation which actually shows us the site of entry, and use whatever is comfortable, either an AL1, AL2 or a rapid right or even a JR. Now the basic standard technique is the right cuspid rule, right cusp rule, where you obtain an iotogram in the coplanar view. The opening, you put in a pigtail there, the opening through the eye of the pigtail actually shows us the opening. And otherwise what you can do is basically you point your AL1 in a posterior direction and start probing with your SFDT wire or a straight tip Teramo, and keep gently rotating the AL1 clockwise till you actually can cross the valve. You can also watch for the whip action or the jet, which actually helps us to know where exactly the jet is, and you can gently cross the valve. Now you can see here, you gently actually rotate clockwise to point it a little posteriorly and go through very gently. And once you cross through, suppose you actually with all these maneuvers you're not able to cross through, the best way is to actually rapid pace, which actually keeps the aortic valve open, and where, because the cardiac output comes down, and during that phase the aortic valve is in an open situation, you can actually cross the aortic valve better. This is in the worst of circumstances. So once your wire is crossed, you pass in your AL1, you don't go to the tip, just pass it through the aortic valve, little through the aortic valve, up to the LVOT, put in an exchange wire, J-tip within the LV cavity, and from there you exchange it. Once you do your hemodynamics, you can always exchange it with the confida, and in case you are expecting too much of horizontality or where you think that you will not be able to cross, use a little undertwist. So basically, once you are in with the stiff wire, it's extremely important that one person is actually keeping an eye on it, because the chances of an LV perforation, which is extremely fatal and probably there is a point of no return, may happen. Sometimes you have your mitral chordae that actually interfere. You may have to actually bring back your pigtail up to the LVOT and reposition it, which actually helps so that you can go up to the apex. Now this is pretty a controversial part, whether to predilate or not. I'll just give you a gist of this because I think I'm running out of time. Bicuspid aortic valves, severely calcified aortic valves, where you think that the valve may not get expanded well. Porcelain, a valve which has extreme amount of, which is very narrow, because during the positioning of the valve you may actually have hemodynamic instability, which may actually cause your valve to get malpositioned. And a horizontal aorta, because horizontal aorta, it may not allow your valve to go through. So dilate it well, and in case you think that there is a potential of a coronary obstruction, where you can dilate the valve as well as give a shot, as you can see here. You can dilate the valve, close it. During the dilatation of the valve, you give injections so that you can see whether the dilated valve is actually obstructing the coronary or not. So that actually helps you in cases of borderline coronary obstruction. You can actually make out whether you are going to land into trouble or not. So these are probably the places where you would want to dilate a valve. But in case most of the studies have shown that a direct TAVR without dilatation, the chances of CVA once you are in with your inline sheath or an So in that situation, there are different techniques which you can use. You can use a push-pull technique where you can see in that we actually pull the wire a little, which actually helped, and push the valve, which actually helps in aligning the valve there. The others are where you can use a buddy wire technique. You can use a Lunderquist in the other opposite pigtail, or you can do another recross with another wire, put another Lunderquist, pre-dilate the second one, or also use a balloon cushion technique where you put a second wire, partially inflate a balloon on the other side, which you actually makes it align and push the valve along. Coming to valve deployment, it's all about sizing the valve. Different valves have different sizes. I won't go into details of this. The best is to deploy in a bicuspid is around -1 to 0, whereas in a tricuspid you can go -2 to even up to 0. But it all depends on a lot of issues and individually. The major issues are if you undersize, the chances of a PVL or paravalvular leak or device embolization is there, and if oversize, you are looking at an aortic root injury, rupture, pacemakers, incidence becomes also very high. So in case there is a diameter is borderline between two valve sizes, consider the smaller valve size if there is severe annular calcification, narrow root or low coronary ostia, narrow ST junction, narrow STJ, mitral annular calcification or a postnal aorta, because the chances of ruptures are much higher. So this is the deployment. This is a my valve where you actually go at the second marker there and do a rapid dilatation, and this is post the valve deployment, and this is a Medtronic valve where you go very gently dilate. It's a self-expanding valve where you expand it very gently and position it. This has actually a chance of recapturability, and therefore you can actually position it more comfortably. And post deployment, basically to assess whether you have done a good job or not, one is hemodynamics to look at the gradients and the AR index, ECG for any conduction abnormalities, and an angiogram to see the valve position, the stability, the aortic regurgitation, and whether the coronaries are filling well or not. So this is the hemodynamics. This is an amazing change in the hemodynamics post the procedure, and post dilatation also will depend upon the hemodynamics. Please don't look for a cosmetic result, look for a great hemodynamic result. I think that is more important. Hemodynamic and an aortic regurgitation is what you should be looking for. Precautions to be taken, and complications are to be kept in mind. So as a summary, it's about teamwork, pre-procedural planning, carefully secure an access site, watch the hemodynamics, and don't take anything for granted. Thank you.
Thank you very much, Dr. Anuj. Because of lack of time, we'll go ahead with the next talk. Tower or Sour Heart Team Approach, Surgeon's Perspective, Dr. Narsingarao.